In this video, we will be discussing the problem of unplanned extubation, and we will demonstrate techniques to prevent it. Similar to catheter-related bloodstream and urinary tract infections, and ventilator-associated pneumonia, unplanned extubation is a preventable cause of patient morbidity. When a patient extubates before ready, the subsequent reintubation procedure can lead to patient discomfort, airway trauma, the eventual need for tracheostomy, and even death. Endotracheal intubation is the most dangerous and stressful procedure that we do in the ICU. In a recent review in Pediatric Critical Care Medicine in 2010, some risk factors associated with unplanned extubations were discussed. They include younger patients, tubes that were inadequately secured, patients that were agitated or undersedated, and copious secretions, performance of patient procedures such as central lines, and increased nursing workload or unfavorable nursing ratios. This review did make some recommendations to curb unplanned extubations. These included standardizations of routines for monitoring endotracheal tubes and standardization of procedures such as tube fixation and patient transport. They did not make recommendations regarding oral versus nasal intubation or tape versus fixation devices. This shows that while there are two ways to intubate a patient and several ways to secure a tube, the main recommendation would be a unit-wide standardization of procedures. In other words, we should make a protocol and hold everybody to it. There are some principles of endotracheal tube security that I would like to introduce based on available literature and some physics. If everybody who is responsible for taping endotracheal tubes follows a standard procedure, it may prevent some unplanned extubations. This is true for both oral and nasal intubations. If we can prevent one unplanned extubation, then going through this whole exercise may be worth it. Proper security is only one factor in preventing unplanned extubation, along with nursing ratios, sedation, and others. But it may be an important factor nonetheless. Maximizing the surface area of adhesion of tape to skin and tape to tube will increase security. And lastly, taping an endotracheal tube is at least a two-person procedure. The most important initial step of taping an endotracheal tube is in the preparation, just like any procedure. And prior to the intubation procedure, everything should be set up, just like doing any procedure. One of the most important considerations is the length of the tape of the endotracheal tube. So two pieces of tape should be torn, both whether it's an oral or a nasal intubation. And the length should be approximately going from ear to ear for the patient. So I'll just show you tearing the first piece. And it's better to tear a piece that's longer than compared to a piece that's shorter, because you can always trim it if it's too long. So the tape should be torn halfway down the middle and then looped upon itself. And the other piece should be torn the same length and again torn down the middle. And you should loop the piece onto itself, and then keep it ready for the intubation. And you should loop the opposite half for each piece. Other equipment, of course, includes mastisol and both a wet and dry 4x4. And your standard intubating equipment, such as suction, a mask, and a bag valve apparatus. Once an endotracheal tube is placed, and certainly during a retaping procedure, there should never be any period of time where there is an unsecured and unheld endotracheal tube. So it's always important for somebody to be holding it at all times. And the correct way to hold it is to wedge it against the corner of the mouth in the case of an oral intubation. And the correct method of ventilating a patient during the period of time where the tube is not taped is one hand holding the tube correctly and the other hand bagging, or another person bagging. What is not acceptable is to bag from above without anybody holding the tube in place. For the taping procedure, the correct thing to do is to first confirm the appropriate and desired depth of the endotracheal tube placement at the lip or at the nostril in the case of a nasal intubation. Then, if in the case of copious secretions, you may want to use either a wet and or dry 4x4 to make sure the face is clean and dry. And once you do that, you take benzoin and you apply it to the areas that are going to be taped, and then you allow it to dry, and then you can commence taping. The first piece of tape can go it can go from the corner of the ear and under. One of the most important parts of this taping job is that the bifurcation of the tape must go exactly at the corner of the mouth so as to eliminate any amount of play between the tape, the face, and the tube. So once that is placed, the first go around should occur circumferentially all the way around. And as you're going around, put some tension on the tape. And then once you've gone around the tube once, then you start marching up the tube. And again, each time you go around, you should pull just a little bit on the tape to create more tension, which increases the security of the tape job. As you can see, I'm putting tension on the tape each go around. And you should march up the tube, never tape onto itself, because it's much more secure to have the tape contacting the tube compared to the tape contacting more tape. And as you get to the end of the tape, you should fold the very end of it on itself for easier access when the tape needs to be removed. So that's your first piece. And your second piece is done very similarly. And as you can see, until the tape job is completed, there's always at least one hand or one finger holding the tube secure. And as you can see, this piece of tape is a little bit too long, but that's okay. I can just trim it at the end. So similarly, the bifurcation of the tape must go right at the corner of the mouth, and the upper part of the tape goes over the lip. And be careful, it's difficult on this mannequin, but be careful to stay off the vermilion border because that can cause skin necrosis. And I'm securing the tape, and similarly, I go circumferentially around the base of the tube, and once I've done that, I march up, putting tension on the tape as I go. And once the tape is nice and secure, I can trim it as needed, and I auscultate equal breath sounds again to confirm placement, and then you can hook up your ventilator tubing and confirm placement finally with the chest x-ray. In the case of either short tubes or tubes that need to be cut short for ventilation purposes, it is very important not to as you're marching the tape up the tube, it's very important not to cover the connection between the tube and the connector, because if this becomes disconnected, it may be difficult to emergently place it back if this junction is covered by tape. And also in situations of smaller tubes or shorter tubes, you should at least march 4 circumferences up the tube, and or 4 centimeters up the tube, in order to increase the security of the endotracheal tube.